This conference will now be recorded.
Okay, so we'll be talking about the gallbladder today, starting with the surgical anatomy and physiology. Just a very short anatomy of the gallbladder. We all know it's got the three parts to it: the fundus, the body, and the neck. And it represents an outpouching of an extrahepatic biliary system. Pear shape, the length is so variable. It can even be more than 10 centimeters long and 3 to 5 centimeters in diameter. The capacity about 30 to 60 ml. Now, what is a very significant fact is whether the Hartmann's pouch, which is usually referred to in all surgical treaties and in all surgical forums, is it really a normal part of the gallbladder or is it an abnormal part of the gallbladder? There's no consensus of opinion onto that part, onto that fact, because one of the points put forward is that Hartmann's pouch is not a normal part of the gallbladder. It is basically an outpouching because of an impacted stone in the neck of the gallbladder. So you can take it either way, as a part of the normal gallbladder or as an abnormal part of the gallbladder or pathological part of the gallbladder. And then comes the cystic duct, which has got prominent mucosal folds. You can see the mucosal folds out here called the walls of Hester, and this helps to maintain the patency of the cystic duct so that the bile keeps coming in and going out as and when required. And there is a sphincter of Lütgens which controls the bile flow of the gallbladder into the common hepatic duct, or the junction of the common hepatic and the common bile duct. So these are the important parts of the gallbladder we're talking about. Now the form and position is important, and when we do laparoscopic surgery, it becomes all the more evident, because often we find that the gallbladder is lying very laterally, and often you find the gallbladder lying in the middle of the at the mid-clavicular line, or it is lying medial to the mid-clavicular line. There's often it's lying lateral to the mid-clavicular line. So what is different? The difference is basically depending on the body type. So if you have a broad body type, which is hyperasthenic type, that means a broad trunk, deep thorax, short thoracic cavity, large abdominal cavity, massive build. In these cases, the gallbladder is higher and lies high up and far laterally. That means opposite the L1 vertebrae. And often it becomes very difficult to put in the third port in these patients, right? The narrower body build type, the asthenic types, it is narrower and lies near to the vertebral cord and maybe as low as the L4 vertebral side. The inner surface of the gallbladder, the mucosal surface, covered by small polygonal compartments opening to the interior, and they resemble the cut surface of a honeycomb-like villi. These greatly increase the absorptive surface of the wall of the gallbladder. This is the histology of the gallbladder. You've got the layers, and what is significant is that there is no submucosal layer. So we're talking about a simple columnar epithelium lying on a lamina propria, which is made up of loose connective tissue, diffuse lymphatic tissue, venule and arterioles into the lamina propria, and then straight away you've got the muscularis. There is no submucosal layer, and this muscularis has got decussating fibers of smooth muscles, and underneath that you've got connective tissue which contains larger blood vessels, the lymphatics, and the nerves. And straight away you have the serosal coat or the adventitial coat, which covers the entire unattached gallbladder surface. It basically means that this serosal coat is absent where the gallbladder is applied to the liver. That is very, very important to remember, because that forms a barrier. The serosal coat is a barrier to the spread of malignancy, and because the serosal coat is missing in the region of the liver, that is why the local extension into segment 4 and segment 5 or directly to the liver is very common when you talk about the gallbladder cancer. So that's the applied importance of this fact that the serosal surface is absent where the gallbladder is in contact with the liver. Now coming to cystic plate, a few words of cystic plate. This was one thing which we never understood when we were undergraduates, even when we were teaching earlier. But later, I think last 10-15 years now, this concept of cystic plate has come in. This is nothing but you all know that the liver's got a capsule, that is the Glissen's capsule. So in this region, the Glissen's capsule is thickened, or it is giving out a connective tissue which is lining the undersurface of the gallbladder fossa, which is the cystic plate. It is lining the porta hepatis, the hepatic plate, and it is lining the area where the ligamentum teres or the fissure is, that is known as the umbilical plate. So the cystic plate is nothing but a part of a 3-plate system, and these 3-plate system, the cystic plate, the hilar plate, and the umbilical plate. So this is the hilar plate in the hilum, the cystic plate. Now, the importance of a cystic plate is that its posterior is located on the right side of the right portal venous branch. So it is ending here and becoming connected with the hepatic plate. Now, this cystic plate, which is lining the fossa of the gallbladder, is thinner towards the gallbladder fundus. That means thin here, and as it approaches the central part, it becomes thicker. And it is perforated by small bile ducts, or often a large branch of bile duct, which we know as ducts of Luschka, which is going to perforate through the cystic plate and enter to the gallbladder, right? The origin of the right middle hepatic vein, which is somewhere here, right middle hepatic vein, lies deep to the cystic plate. So this is the applied importance of cystic plate, that when you're trying to remove the gallbladder, if the cystic plate is present, always remove the gallbladder without the plate. Remember that. The dissection should be between the plate and the gallbladder surface. It should never be along with cystic plate. It very often happens, especially when you got chronic cholecystitis. There the cystic plate is so adherent to the gallbladder, it's often not possible to leave it behind. So the whole cystic plate comes in, and when it comes out, you can easily visualize that the gallbladder, the liver starts bleeding. You can see the surface of the liver being torn. So remember, when you got the cystic plate and you got a gallbladder which is not really chronic cholecystitis, always dissect in between the cystic plate and the gallbladder, right? Now, the congenital development abnormality of the gallbladder and ductal system are important. I've just noted down the important ones, which are very common, and that is the lobed gallbladder. You often find a Phrygian cap. You can see it out here. The floating gallbladder, when you got a mesentery to the gallbladder, and you can find the gallbladder floating, and becomes very easy to remove it if it is a pathological condition. Now, the important part is the abnormality of the cystic duct origin. And these are the abnormalities which are very, very important. Why you have to know them if you have to carry out a laparoscopic cholecystectomy or cholecystectomy without complication. See this. This is cystic duct, and you ligate it out here. What are you ligating? You're ligating the right posterior sectorial duct. Here, you ligate one, you leave the other. What are you doing? You're leaving the CBD open. You ligate, you feel this is the cystic duct because here it is arising from the right hepatic duct. And you ligate it here. What are you ligating? You're ligating the right hepatic duct. Here, see this. The right sectorial duct is coming to the gallbladder, and the gallbladder is then joining by the cystic duct. You do a cholecystectomy, ligate it here, and you remove it. And when you remove it, you find there's a duct entering here also. Now, what have you done? You have removed the right sectorial duct. So in this case, it would have to be removed out here. Similarly, out here. So the ductal system abnormality, or there are conditions where, or there are instances where you don't have a cystic duct. The gallbladder is directly opening into the common bile duct. So these are the areas which have to be remembered. These abnormalities, congenital abnormalities, are very, very important, and that is why it is said that you should always, before applying any clip or before cutting the cystic duct, if you do open cholecystectomy, always visualize that there is no other duct entering into the gallbladder. Please be careful, and that is where the critical view of safety comes in. We'll talk about that when we talk about the laparoscopic cholecystectomy. Now, coming to gallbladder vascularity, the arterial supply typically to the right hepatic, the cystic artery branch comes from there, divides into two, the anterior and the posterior, and it supplies the gallbladder. The superficial branch or the anterior branch passes subserosally, that means under the serosal surface, over the left aspect of the gallbladder, and the deep branch of the posterior branch between the gallbladder and gallbladder fossa. Because remember, there is no serosa in the gallbladder fossa, in the area of the gallbladder fossa. So there it is running on the gallbladder surface and terminating at the peritoneal attachment to the liver surface. Now, remember one thing, that the variations in the arterial supply and the variation ductal system is so common that it is present in more than 33% cases. Now, when the cystic artery comes here, there is a choledochal artery coming out from the right hepatic duct. That is got applied importance, and that is why it is always said that if you have to tie the cystic artery when you're doing cholecystectomy, tie it near to the gallbladder. If you tie it here, you're not going to damage this choledochal artery. You tie it near to the hepatic artery, you are going to damage the hepatic artery, you're going to damage the choledochal. And if you damage the choledochal, then that is one of the reasons why you have a post-operative biliary stricture formation. Remember that. So the dictum always holds true. Cystic duct near to the CBD, cystic artery near to the gallbladder. Now you know the reason why that should be, right? Now, aberration cystic arteries are common, as I said earlier. In 1/3 patients, you can have a double cystic artery, both arising separately. So you find one cystic artery entering out here, and you ligate it, and then you start with the gallbladder. And suddenly, what do you find? You find torrential bleeding. Now, where has the bleeding come from? Because the deeper branch was arising separately from the hepatic artery. So you have a double cystic artery, or a cystic artery arising from the left side of the hepatic artery. That means arising from here. I'll show it in the next slide. Arising from here. So it's going to cross all behind or in front of the common hepatic duct. And that is basically a problem again. You can have a recurrent cystic artery where arising from the gastroduodenal, going up to the fundus, and then curving back to supply the neck and the cystic duct. So that is a recurrent cystic artery. That means goes to the fundus and then creeps back in. And that is also a very common scenario where you got a low-lying cystic artery arising from the gastroduodenal or arising from the superior mesenteric artery. So these are the aberrations that you have, you can find. Then you got the Moynihan's hump, which is an abnormal caterpillar hump. These are just figures of that. Now, basically, you have two kinds of abnormality with the hepatic artery. You can have aberrant course of the hepatic artery, or you can have an aberrant origin of the right hepatic artery, giving rise to the caterpillar hump. Now, see this hepatic artery. Can you see this curving? It's lying in the callous triangle. Now, you do a dissection and you ligate it here. What do you ligate? You ligated the right hepatic artery. See here, again a hump here. This is the right hepatic, and you ligate it out here. So this is to be ligated, not this. So this is an important abnormality that you have to remember. And then, of course, the apparent post right hepatic artery. See this right hepatic artery curving here inside the callous triangle. This is not the Moynihan's hump. Moynihan's hump is curving across the duct, curving across the duct. That is the Moynihan's hump. This is not the Moynihan's hump. This is an abnormal course of right hepatic artery. So what I am trying to put across is that you can have an abnormality in the course of the right hepatic artery, and you can have an origin of the right hepatic artery. In both the scenarios, you have to be very, very careful. And that is why, remember, always ligate the cystic as close to the gallbladder as possible. There you would be free of any of these complications, right? A very good figure. See, all these are the aberrant cystic arteries. Here you find the right hepatic, the typical, coming from the left hepatic. See, crossing in front of the common hepatic. Here, coming from the gastroduodenal artery. Again, here, cystic artery from the right hepatic, but crossing in front. That is again an abnormality. Here, again, from the right hepatic towards the base, again crossing at the junction of cystic duct. So, all these are. So, here, if you're ligating it here, you're safe. Ligate it here, you're safe. Ligate it here, safe. Doesn't make a difference where it is arising from. So always tie the cystic artery as close to the gallbladder as possible. Remember that. Now, terminology different, that is the hepatocystic and callous triangle. Are they synonymous? Here they are synonymous. Hepatocystic triangle is now synonymous callous triangle. Now, the word now is important because now both are considered the same. Now, this is what is the hepatocystic triangle, which we know typically the lower part of the liver, and you got cystic duct and the gallbladder, and you got the biliary channel, that is the common hepatic duct. And this was the callous triangle, that is what we know, and that is what is the hepatocystic triangle. But what was the original callous triangle? The original callous triangle, which was described in 1891, was not this triangle. It was a triangle where the cystic artery was forming one of the borders of the triangle. See the yellow part. In the today's callous triangle, the cystic artery is a content of the callous triangle. Okay. In 1891, the callous triangle, the cystic artery was a border of the callous triangle. So see this blue, this is now the new callous triangle, also known hepatocystic, and that is why the cystic artery, often the right hepatic artery, the cystic vein, and the cystic lymph node, which is known as lymph node of Lund or the Mascagnes lymph node, are the normal contents. The three contents, always remember, the cystic artery, the cystic vein, and the cystic lymph node are three important contents of the callous triangle. May also contain the right hepatic if you've got a caterpillar hump or you've got a curving out here. You can have an accessory right hepatic artery. You can have an anomalous right sectorial bile duct. So all these are the six are the contents of the callous triangle. Three normal and three abnormal, right? And that is why dissection in this triangle is ill-advised until the lateral most structures have been cleared. So what does this mean? This basically means please do not start your dissection from here. Always start the dissection from here and from here. Never start the dissection in this area. Never do it. If you're going to do it, you are bound to create problems for yourself and for the patient. And that is why, remember, Gallow's dissection always starts from lateral to medial, lateral to medial, lateral to medial. Never forget this. Always lateral to medial. Okay. Now, this was the original callous triangle, and this was basically the cystic and the cystic duct, and the original callous triangle of 1890. Okay. Now, coming to venous drainage, now they are veins which are not very clear-cut veins. They are veins, there are plenty of veins. They're draining directly into the liver. See these veins into the liver, or you can have a cystic vein draining directly to the portal system. The portal system is here into the hepatic, into the right portal vein, or directly a branch into the common portal vein or the common portal. So most of the veins around the neck, they drain into the portal system, and you can also have some veins draining directly into the porta hepatic. So three areas where you have the venous drainage of the gallbladder. The coming to the lymphatic basin is very important, and the plexus are two: one underneath the serosa and one submucosal. So there are two plexuses, submucosal and subserosal, and the primary drainage is always towards the cystic lymph node. Secondary drainage, that basically means onward. I wouldn't call it a secondary drainage. The onward drainage, then from here it goes to the portal and it goes to the paracholedochal. These are pericholedochal, right? From the pericholedochal lymph nodes, then it goes to the retroportal and it goes to the posterior superior pancreaticoduodenal, right? So the superior and last part is the interaortocaval lymph node. So the cystic lymph node is the first station of drainage. The subsequent station of drainages are basically the choledochal, the retroportal, superior pancreaticoduodenal. See, the portal is coming out here, and then of course superior mesenteric artery and the interaortocaval. One thing to remember is that the subserosal lymphatics can also join the hepatic subcapsular lymphatics and form a direct contact. And where is this going to occur? In the area of the cystic plate, that is the area of contact of the gallbladder directly with the liver. The nerve supply, the parasympathetic is motor. Hepatic branch of anterior vagus contracts the gallbladder, relaxes the sphincter, so the gallbladder empty. 75% of the contents of the gallbladder, they empty in the postperineal phase. That means as soon as you have your meal, within the next half hour, 1 hour, 1.5 and 2 hours, 75% of the gallbladder should empty itself. It is not empty, it is a pathological gallbladder. The sympathetic fibers, preganglionic, are from the lateral horn of T5, T9. We all know that the thoracic sympathetic outflow goes to celiac ganglion, synapses at the celiac ganglion. The postganglionic fiber, they come and supply the gallbladder, they relax the gallbladder, but also contract the sphincter of Oddi. So diagrammatically opposite, parasympathetic gallbladder contraction, relaxation of sphincter. Here, sympathetic relaxes gallbladder, contracts sphincter. Sensory fibers, occasionally some fibers of C4, 5 are short-circuited to the celiac ganglion into the gallbladder through the sympathetic supply. This is a very important fact. Why? Because gallbladder anatomy, why should you have a right shoulder pain in gallbladder pathology? Easily understandable. When you got acute cholecystitis, your parietal peritoneum is getting irritated, the parietal peritoneum underlying the diaphragm gets irritated, and you got right shoulder pain. Very good. We all know that. Why? Because the diaphragm is being supplied by the phrenic nerve, C3, 4, 5. We all know that. But why should that happen in an uninflamed gallbladder? And the reason is simple, and that is a few fibers of these sensory fibers, they short circuit with fibers of the right phrenic nerve through connection in the celiac ganglion. So there is short circuiting in the celiac ganglion between the fibers of C3, 5 along with the fibers which are coming from the phrenic nerve and the gallbladder. So that short circuiting of fibers gives rise to the pain even in those patients where there is no inflammation of the gallbladder. Acute cholecystitis is very easy to explain, right shoulder pain. In a non-acute cholecystitis, it's very difficult to explain. Coming to the extrahepatic biliary system, it is just a simple fibrous tube. The whole thing is a fibrous tube lined by columnar epithelium, right? So this tube does not have any muscle. The muscle is only localized in the region of the sphincter. So the muscular cord is the sphincteric cord. The choledochal duodenal junction is an oblique path, and it could be three types. Number one, the most common, you have an ampulla, that means the ampullary type of opening. The number two is a separate type but opening at the same, but they got separate course in the wall of the duodenum, and absolutely separate course and absolute separate openings in 3% of cases, right? So the most common, of course, the ampulla, 30% no ampulla, but still running very parallel close to each other and has common opening, and disparate or separate opening in 3% of cases, right? Now, the muscular is only the sphincter area, and that sphincter is made up of 4 sphincters. The muscle at the choledochal junction are 4, we got 3 choledochal components and 1 pancreatic component. So sphincter ductus choledochi, it has got 1, 2, and 3. 1 and 2 is basically the proximal and distal part of the common bile duct. That is 1 and 2. And this is the pancreatic, the distal part of the pancreatic duct, and that is the number 4. And you've got the common sphincter, which is common to both the CBD and the pancreatic duct, and this is 6 millimeters. So the length is important. The 6 millimeter, and this is basically 10 millimeters together, right? Together making the whole complex about 2.5 to 3 centimeters, but this again varies depending on the thickness of the duodenal wall. Now, this common sphincter has got thick circular longitudinal fibers interspersed with numerous glands. That is very important. That is where the periampullary carcinoma arises. You may be wondering, where does the periampullary carcinoma arise from? The periampullary carcinoma arises from these numerous glands which are interspersed in between the muscle fibers and the wall of the duodenum in this particular area. So what is the clinical importance of this? The clinical importance basically is that this is the proximal occlusive zone. The middle part can easily be dilated, and the sphincterotomy is usually done in the distalmost part. So whenever you do a ERCP, when you're doing ERCP, especially in those cases where you got to put in a stent and you find it's a very tight, then you do a sphincterotomy. So where do you cut? You're basically cutting only this sphincter, right? This gets dilated. So you do a dilatation and you cut the sphincter, that should be enough. If you cut too much, then the problem of duodenal wall injury occurs and problem of regurgitation occurs into the ductal system and chance of acute pancreatitis. So remember, it is very important that whenever you do a sphincterotomy, you're cutting sphincter number 3, and whenever you're doing a dilatation, you have to dilate 1, 2, and 3. All of them have to be dilated, right? Now, the bile acid and bile salt metabolism, just a few words about this. You need to know this. Why? Because we have to understand what is happening obstructive jaundice and why should the patient be developing gallbladder stone. So the bile acid, the bile salt metabolism in the liver, and then subsequently. So you got the 2 primary bile salts which are synthesized in the liver from cholesterol. We all know the basic is the cholesterol, and 80% of the bile salt pool is generated in the liver by the 7-alpha hydroxylase, breaks the cholesterol into the lipid soluble cholic and chenodeoxycholic acid. Remember, at this time it is lipid soluble. Once they are formed, they now get conjugated with taurine and glycine, 1 and 3. This is terminology of physiology. I'll be running very fast with this. So that creates a water soluble bile salt, right? Once it gets combined with sodium and potassium. So you got the taurocholic acid, glycocholic acid, this combining with glycine and taurine. This combined with taurine glycine will give what? Tauro-chenodeoxycholic acid and glycochenodeoxycholic acid. Very simple to understand, right? And then they combine with sodium potassium to give rise to the corresponding salt. These salts are water soluble. This was lipid soluble. And this synthesis of these salts is governed or controlled by a negative feedback mechanism occurring from the intrahepatic circulation from the ileum, right? So 7-alpha hydroxylase, cholic acid, chenodeoxycholic acid, taurine glycine. So taurodeoxycholic acid, glycocholic acid, similar. So this part is lipid soluble and this part is conjugated. So this is water soluble. This is occurring in the liver. Okay. Now let's go further. Now, once it reaches the intestine, now the intestinal bacteria act on the primary salt to generate what are known as secondary bile salts. Not the total. Part of the primary salts is broken into secondary bile salts, generating what? Deoxycholate from folic acid and lithocolate from cherodeoxycholic acid. So your water soluble bile salts have reached the intestine, and their part of it gets acted upon by the bacteria to generate secondary biliary salts. And even those secondary bile salts are further acted upon by the bacteria to further deconjugate them. So now you have got a 95% of primary conjugated salts, which are the secondary bile salts, less amount, which have been broken down. And these are going to be what? They are going to be recycled, reabsorbed in the ileum, and then they go back to the liver. And when they go to the liver, the hepatocyte extracts 92% of these in a single passage. That basically means that suppose if 100 salts are coming into the intestine, 95 will get absorbed, and from the 95, 92 will be extracted in the liver. Only 3 will remain behind in the blood. So that is a huge amount of absorption which is occurring out there. So the hepatocyte is extracting 92% of these which have reached there into the liver. So 95. So that means that leaves only 5% in the intestinal lumen. 95 absorbed in ileum, 5% remaining in the intestinal lumen. What happens to this 5%? I'll tell you what happens. The remaining 5% intestines are bacterially deconjugated, and parts are reabsorbed after deconjugation, and part go into the feces. That basically means each bile salt recycles itself at least 18 to 20 times, and 2 to 3 grams of bile salts are recirculated at each time. The active transport of bile salt by the liver is the major factor which regulates the volume of your bile secretion. And the rate at which they are returned to the liver by the enterohepatic circulation regulates the hepatic synthesis of bile acids. So remember, the enterohepatic circulation is a very, very important circulation. So what is going from the ileum to the portal is the primary and the secondary bile salt, the primary secondary bile salt, and primary unconjugated liver reconjugated again. They get reconjugated again and then pushed back into the liver. See, this is what is happening. Now, what I want to draw your attention to in this figure, which is very, very important, is that there are almost 4 methods of bile acid returning to the liver. So here, synthesized into the gallbladder. At this point itself, in the wall of the common bile duct and the common hepatic duct, there is absorption. There is absorption, what is known as cholangiohepatic shunt. Gets absorbed. Where? Back into the liver, number 1. Number 2, it also gets absorbed by passive absorption into the bloodstream directly. See, you can see an arrow out here. Number 3, a spillover into the systemic circulation. So 1, 2, and 3 are the lesser known and lesser important methods of the bile salts returning back into the liver. The most important, of course, is the ileal active transport. This is the most important. So from the intestine by the ileal transport, it is going ultimately to the liver. But remember, there are 3 other alternatives. 1, the spillover into the systemic circulation. Number 2, absorption through the walls of the extrahepatic biliary channels, and the cholangiohepatic shunts, which are important for the reabsorption back into the liver. So that is the enterohepatic circulation. Remember this. This is the major 95% is this, but we have to remember these also, because these come into play when there is a, say, obstruction here, obstructive jaundice, block at the lower end of the CBD. So what's going to happen? How are the salts going to come back to the for further synthesis? So that these 3 alternative channels become major and important channels to push back the bile back into the liver. Now coming to the biliary pigments, just a few of the biliary pigments. You know that the bilirubin and porphyrin, hemoglobin, hemoglobin, biliverdin, and formation of bilirubin, which combines with the plasma albumin and goes to the liver. So far, so good. So now the hemoglobin, the RBCs have been broken down. Where they broken down? Primarily in the spleen. Major, of course, they're broken down even in the liver, but the primary is the spleen itself. So ultimately, what is happening? The bilirubin combines the plasma albumin and goes to the liver. This is what's happened. Breakdown. See, just what I said, globin, heme, bilirubin generation occurring where? At the spleen level, and now uptaken into the liver. Now what happens in the liver? In the liver, now this bilirubin gets conjugated. Until now it was insoluble. Now it gets soluble. Why? Because it's conjugated with what? glucuronic acid. So conjugated into conjugated bilirubin with glucuronide, sulfate, and other soluble forms. But the major is with glucuronic acid. Now this soluble conjugated bile, now the pigment now enters where? Into the intestine, right? Now when it enters the intestine, it is acted upon by the bacteria to form what? Urobilinogen, which is nothing but a combination of meso and stercobilinogen. Now, what happens to the urobilinogen, which is out here? One, it can go into the feces, forming stercobilinogen. Number two, it can go back into the liver as urobilinogen reabsorption, and from there, it goes into the kidney. So, see the 7 important parts in the pathway of urobilinogen or bilirubin pigment: generation, conjugation, uptake in the liver and conjugation, going into the intestine, broken down, partially stercobilinogen, partially reabsorbed back, reabsorption through the bloodstream into the kidney. So that is the whole bilirubin metabolism for you, right? This is just nothing but just a repetition of what we just saw said, right? So a healthy liver can metabolize and excrete 10 times the normal amount of bilirubin produced, right? So that means if you're producing a particular amount 10 times the normal, 10 times the normal, so that the liver has got that much capacity. And that is why even in massive RBC breakdowns, you do not have a very sharp rise of bilirubin level. Why? Because the liver is going to take care and metabolize that bilirubin. Therefore, remember, this part is very important. Plasma bilirubin concentrations are considered insensitive tests of liver function. You cannot say that the patient has got, let's say, a 2 mg/% and this patient does not have major jaundice. He may be having a major amount of bilirubin generation. Why? Because the liver is taking care of that amount of generation. Therefore, it is not a very sensitive test, it's an insensitive test. The bilirubin that is normally present in plasma is 95% unconjugated. Remember, absorbed, this is unconjugated. That is what is existing in the plasma with albumin, 95%. So it is unconjugated and insoluble. Since it's protein bound, water insoluble, unconjugated bilirubin is not filtered by renal gallbladder. It's very simple. So that bilirubin is never going to appear in the urine. Why? It is in combination with albumin. It is insoluble. How is it going to appear in the urine? It cannot be filtered. So remember that insoluble bilirubin will never appear in the urine. Therefore, if you have an abnormal presence of bilirubin in the urine, it reflects a high concentration of what? Conjugated bilirubin. And that can occur when? It can only occur subsequent to this stage. Subsequent to this stage. That means if it gets absorbed from here, only then it can be excreted in the kidney. So that basically means what? That basically means that whenever you've got a bilirubin in the urine, it is conjugated and this patient has got obstructive jaundice, right? Right. Are the extrahepatic biliary system functionless? No. The bile ducts are not simply conduits. They have a profound influence on the form and composition of the bile. And what form and composition of the bile? One, they transport the bile, that we all know that they have transport, they regulate the flow by the sphincter of Oddi. Number two, they have got storage and concentration of bile, especially after cholecystectomy. They start acting partially like gallbladders. Bile duct walls are highly permeable. And how do they do that? They're highly permeable to sodium and potassium, so that ducts are involved in biliary absorption. So they carry out some amount of absorptive function. And they also have a secretory function. They can secrete water electrolyte and the cholerectic action of stimulants such as secretins. Remember, they are mainly on the bile duct rather than on the gallbladder. That is a point which has to be understood, that secretins are primarily acting on the gallbladder, not on the gallbladder, on the extrahepatic biliary system minus the gallbladder. That means the ductal system. And how do they act? Increase amount of secretion of water and electrolytes. Now, what happens to the extrahepatic biliary system post cholecystectomy, which is a very, very important point. Why? The reason is that you have done a cholecystectomy, the patient comes back to you with a lot of pain, and you get ultrasound done, and you find that the gallbladder, the CVD is now dilated, and you immediately start thinking, oh, I probably missed, or we probably missed a stone in the CVD, and that's why he's having pain. Not true, not true, because the CVD may be dilated normally, physiologically, post cholecystectomy. So you've got dilated biliary ductal channel with a high sphincter of Oddi tone, may result in back pressure and altered hepatocyte function. If the sphincter odi, so it all depends upon the sphincter odi. If the tone is high, back pressure, hepatocyte function gets altered, the patient may have mild jaundice. If the sphincter tone is low, there's a constant dribbling and wastage into the duodenum, and this patient starts having a lot of gastric symptoms. Acids start being stored in the proximal and small intestine also. So three important things. One, dilatation of the bile duct. Number two, back pressure effect. Number three, constant dribbling. And number four, the bile acids and salts, they start getting stored in the proximal small intestine, which takes over partial function of the gallbladder. So the proximal intestine now also starts as acting as a gallbladder. The contents of the bile, 95% inorganic, 5% organic. Among the inorganic, the sodium, potassium, all these electrolytes are important, but water is the major component. But among the organic, almost 50% and more is bile salts, and a very small amount of bile pigments, and 25% of lecithin. The others are, of course, the cholesterol and the fatty acids. The hepatic bile, so that means we can talk about the hepatic bile, we can talk about the gallbladder bile. The hepatic bile is secreted into the gallbladder at about 600 to 1 liter per day. This is a very important figure to be remembered, especially in post-cholecystectomy, when you got a drain in and the patient is having biliary drainage in the drain for some mishap which may have occurred. Then you start wondering how much bile is coming. Is all the bile draining? So you have to know how much bile is being produced in a particular patient. So anywhere from about 600 to 1 liter of bile per day, right? Osmolality, of course, it has to be isosmolar to the rest of the body osmolality. The hepatic bile is unique in the fact that it's an exocrine secretion and excretory pathway. Why is it exocrine secretion? Because it has got conjugated bile salts. Why is it excretory? Because biliary pigment is basically an excretory function. That is not exocrine secretion. And cholesterol, lecithin, and fatty acids are excretions which are coming into the bile, right? What happens to the bile in the liver, from the liver in the gallbladder? See, water becomes 92%, bile salt 6%, bilirubin, cholesterol, all increasing. So there is an overall concentration of bile salt, pigments, and cholesterol to the tune of 6 to 10 times from the liver to the gallbladder. So in the gallbladder, it is being concentrated, the liver bile becomes 6 to 10 times concentrated in the gallbladder. And how does it occur? By a combination of absorption, secretion, and motor activity. Three things are occurring which are occurring at the level of the gallbladder, which concentrates the bile to 6 to 10 times to what it had received from the liver. Okay. Now the mucosa has got the greatest absorptive capacity, and what are the methodology of this concentration of 6 to 10 times? One, sodium chloride is absorbed actively, water is absorbed passively, potassium, calcium are absorbed, and bicarbonate also is absorbed because it comes 2 times of that in plasma. So that is the mechanism by which concentration is occurring. So what are the functions of the gallbladder apart from concentration? Number 2, it acts as a biliary reservoir and exemplified by the fact that the rise serum bilirubin level after CBD ligation. Now, if you have ligated the CBD with the gallbladder present, then the bilirubin rise only after 2 days. See, 46 to 48 hours. This is a very important thing to remember. Remember, you have done a cholecystectomy and you've ligated the CBD. When do you expect the bilirubin to rise? 6 hours. Very important for we as surgeons. All the postgraduates, if any one of them are there, or even the UGs, remember this always, because this is a very important fact to remember when you're doing a post or you're analyzing a patient of post cholecystectomy rise in bilirubin level. So if the gallbladder is still present and you have ligated the CBD, the rise would be only after 2 days. But as is done after cholecystectomy, if there has been a ligation of CBD, then the rise would be within 6 hours, right? Changing reaction of bile, that is another function of gallbladder, and changes from 7.5 slightly alkaline to the to about higher, that is 6.8 to 7.65. So say the minor alteration of the pH. Now bile in the gallbladder becomes more acidic. Secretion of mucus 20 ml per day. Calcium is secreted by the inflamed mucosa, right? Now In obstructive jaundice, the total bilirubin is positive, mainly conjugated. I just now told you, remember, what is going to the bloodstream? After conjugation. After conjugation. So, conjugated bilirubin. Bilirubin in urine, high levels of conjugated bilirubin blood can move into the kidney and get excreted because water soluble. So, the bilirubin in urine is basically the conjugated. Urobilinogen stools, no, because nothing is coming from the CBD into the intestine. So, no, that's why you get the clay colored stool. No urobilinogen in urine. Why? Again, because there has been no absorption in the intestine level and no urobilinogen in these two. So that is important. That is what you find in a obstructive jaundice. So the biochemical profile, obstructive jaundice, conjugated bilirubin increase, urine bilirubin positive, urobilinogen will be absent. Alkaline phosphatase always raised. Remember this. 3 enzymes to remember. Most important, alkaline phosphatase. Less important, gamma glutamyl transpeptidase, GGT, 5-nucleotidase. ALT/AST may rise, may not rise. Why? Because they're reflections of the hepatocyte function. They're not reflections of the obstruction. So they or may not be, they may or may not be in a higher level. Albumin is decreased. Growth hormone time always prolonged because the absorption of clotting factors decreases, which are vitamin K dependent factors. And these are the patients where you have the problem with bleeding. Now, I'm not going to go to this figure. I think we leave it here today. I have to attend another class, and we'll continue the function of bile and the rest of the gallbladder next time. If you have any questions, you always come back to me. Thank you for your time.